Which kinds of internal derangement can we see? Well, in fact, it's all about an intradiscal pressure game. Discs can move in each direction. You could have a more posterocentral internal derangement, a more unilateral one, a more posterolateral one, ventral, vertical, circular one. So depending on the direction of the derangement and the size of the derangement, of course, the clinical image can be totally different. If we look in the posterocentral direction, then the most frequent category is going to be the small internal derangements with pressure against dura. The bigger ones, acute lumbago, are of course also possible, but we hope that it doesn't become too big and that the patient gets cauda equina. Of course, there could be also more, let's say, unilateral displacement, so the patient can have more unilateral symptoms. If a patient has an acute lumbago, a big protrusion with pressure against dura, he not only has central back pain, but he also has bilateral back pain, and he has multi-segmental radiation of pain. But I come back to that a little bit later on. If we look at the posterolateral direction, so we talk about patients who have a sciatica, then the secondary posterolateral protrusion is much more frequent than the primary posterolateral one. And what exactly is the story? Well, in the primary posterolateral protrusion, there was leg pain from the beginning. There was no back pain. The protrusion, the derangement was immediately lateral without previous dura contact. That happens mostly with younger people. Younger people, probably more nuclear internal derangement, probably they react better on mechanical traction. But I refer to the lecture on the history for more information about that. The secondary sciatica, well, the patient had first back pain, perhaps central back pain, unilateral back pain, then he got a shifting pain, he got leg pain, but no more back pain. This is more frequent, of course. But a real sciatica in itself is less frequent than a discodural conflict. There is some controversy about compression on a nerve root. According to some studies, stimulation of a normal nerve root does not produce a pain response. But a stimulation of an already swollen or compressed nerve root produces leg pain. The problem is, we don't know how much pressure we need, how long the pressure has to be there, how much mechanical stress should be there before those changes occur so that the nerve root becomes sensitive. This is still a question mark, and another question mark is, how can we then explain rapid centralizing pain due to manipulation? Let's imagine, pain has radiating pain in the leg, we do some treatment technique, and immediately after the treatment technique the pain in the leg is better. And slowly but surely he gets centralization, he gets back pain and no more leg pain. An important remark is also going to be, and I also mentioned that in other lectures, the majority of people with radiating pain in the leg don't have a sciatica. They have multi-segmental reference of pain from the dura. How do we know that? Well, I explained that in detail in the specific lecture on the history. If there is more ventral internal derangement, that could be related with Scheuermann's disease or the mushroom we also discussed in the chapter on the history. In the vertical direction, we can see Schmorl's nodes. We can also see a biconvex disc and a biconcave vertebra, for instance, in the case of severe osteoporosis. And this is in fact the most important slide when it comes to internal derangement. We put the puzzle pieces together. What's the difference between a small internal derangement and a bigger one? Well, of course, both of them we see a partial articular pattern. But with the bigger one, there's more pain, more limitation of movement. The smaller one, there's not too much radiation of pain. They have some back pain, unilateral pain, some cranial gluteal pain. With a bigger internal derangement, there should be much more radiation. Multisegmental radiation, when there is pressure on the dura, or segmental radiation when there is pressure on the nerve root. Do we expect a painful arc in bigger protrusions? Certainly not. A painful arc on flexion and straight leg raise is typical for small internal derangements. What happens when you cough or sneeze? When there is a bigger internal derangement, those dural symptoms must be positive. With a smaller protrusion, it could be. And the same applies for the dural signs. Yeah? We do the straight leg raise and then accessory neck flexion, or we do the flexion in standing and accessory neck flexion. With the bigger internal derangement, we must have dural signs. What about the straight leg raise? Well, we discussed the different stages of the straight leg raise in the lecture on the functional examination. Remember? Just to summarize quickly, straight leg raise is negative, end range pain, painful arc, small internal derangement. Straight leg raise is painful, limited, bigger. Painful, limited, deficit, even bigger. Of course, with a small internal derangement, you don't expect deficit. And finally, the inspection. Did we see a flexion deviation or a lateral shift deviation? Well, with the bigger protrusions, yes. With the smaller protrusions, certainly not. So keep those things in mind, because those are the important puzzle pieces which are going to be useful later on when we talk about indications and contraindications of manipulation and traction.